update strategy priorities just before lunch. And I need to keep to time for item 3.2. So I'm going to change the agenda slightly, go to item 3.3, which is to receive a report on the development of the annual plan 24-25 from the Great Strategy, Larissa.
Yeah, so this is doing two things really. One is to sign off. So we've been through the strategic objectives and a couple of informal board sessions through development or through informal boards. So it's just to formally ratify them so that those form the basis of our plan. And then it's also just to describe the process we're going through at the moment in terms of the development of the plan. So it's a three-pronged approach. So we're developing the priorities from within the organisations and we identify in there the kind of must-dos that we're aware of. The planning guidance hasn't been published yet, so so that might change some of that as we work that through. So that won't get published until much closer to Christmas, I think. And then we also haven't had the financial framework. So, and again, that will change things. So it's a bit of an iterative process as those two things take place. And we have some time with the exec to start to prioritise the priorities, if you see what I mean, so that we can start to go through this. Running in tandem with this, my team are doing the strategic elements, but they're also linking in with finance to look at the cost pressures, etc., etc. So that we've got a kind of a programme really as to come forward on priorities. I think given the financial challenges we've got, I think Darren raised it at management board, this isn't going to be enough to be able to address the issues going forward. So I think we've got to think through some of the bigger programmes of work linked through to what the Welsh Government are doing around sustainability. So things like CHC is a big programme, procurement, and so link internal kind of strategy to that. And there's also, I think, more we need to do around operation productivity and getting more out of what we're putting in. So we've minimised the levels of GMOs this year simply because of the financial position, and we're just pointless people doing a load of work that they can't then fund. So that's just the process at the moment, so it gives you a bit of an overview to that and formally signs off the strategic objectives.
Thank you, Larissa. And it is good to have the strategic objectives because we're starting to put, it is disappointing that it's going to be an annual plan, not an IMTP, but at least we are still pushing it in a strategic context. Any questions or thoughts for Larissa? We're being asked to approve the strategic objectives and to endorse the next steps that are set out in the paper.
It's just to Larissa's point, actually, we will put together the jigsaw of the many as that when that becomes available to us. So that will be determined by the success of the plan we discussed prior to the program. The other thing is, I think we do need to test ourselves in this process about what 3 years worth of recovery could look like.
Yeah.
So whilst it might not be an approvable IMTP, I think part of our discipline should be to have that forward looking to see what the steps might be to get us the form of financial sustainability.
Yes.
As a challenge, I couldn't guarantee that yet, but I think it just has to be something we keep in mind.
I think that's very important. I think we absolutely should be doing that. Yes. Nuria.
We discussed this in our board meeting, development board. I was trying to find the word. I don't know what we call them. Our development board meeting, and I think for me it's a bit about that working around objective one and how we work with partners and the role that they play, which I think we need to draw.
Yeah.
Because obviously we're not going to sort out all these problems by ourselves. And I think linked to that is the quality statements on objective one, having them all as our well-being objectives.
Yeah.
I don't think we'll fulfill our future generation objectives, and because they're supposed to be cross-cutting across the borders. So I just think we just need to rethink that element to the Future Generations Act.
A couple of people have raised that with me. What is the main issue? Is it because we deliver it through partnerships and it isn't wholly us? Is that the sticking point with it?
No, there's two different points. So on point one, which is around the objectives, where we're saying that we'll provide fair employment, etc. That is about partnerships, and that's about being clear what the role of partners is, because we won't be able to deliver that objective by ourselves. So we need to be careful because we'll be accountable for these objectives. Yeah. And then the second element of that is around, it says that the quality statement under objective one will be our well-being objectives. Yeah. But actually our well-being objectives need to run across
Yeah,
all of the objectives.
okay,
So it's about the structure of that.
okay,
Do they though? I mean,
My
I
understanding is
mean,
that they do.
Our wellbeing objectives are how we meet the Wellbeing of Future Generations Act.
it is, and we've got to, so statutorily, we have to report on the wellbeing objectives. What they've tried to do is to take those wellbeing objectives and apply them to the strategic objectives of the organisation, so we're not reporting twice, because
Yes.
it's messy. And what you're saying is that you're not comfortable that they do.
But according to what I know, is they need to run across. I mean, you can ask the future generations
Yeah.
team just to have that clarity.
Is it how we report on them though? I mean, is your concern that you're limiting the wellbeing objectives
To that
to a
one,
particular
yes,
thing
that
as
is-
opposed
that is-
to
oh,
everything that we do?
I get you. Well, it can be to all of them then, can't it? We can implement, we're doing the wellbeing objectives, it's not just the first one, it's all of them. We're using those wellbeing objectives to
But it's
underpin
how- Yeah,
our strategic
So it's-
objectives.
yeah.
Okay,
Yeah, okay,
Yeah.
thank you, thank you.
that's a fair point.
Yeah.
Okay, yeah.
Okay. Any other thoughts on this? Steve?
Just to record, I've given up fighting the battle against prosperous.
which is good because it's still there.
If you wanted to say flourishing or thriving, prosperous works.
Yeah,
I think it would be good to see the next level down, the more action planning on strategic and objective one. Because these are still very generic, and I think more helpful specific actions that probably from the next
yeah,
level
there are.
will
So-
make us a more proactive in this
Yeah.
space.
So
So
we've got to go down the level. Yeah,
it will mean that we can understand what contribution, I think, things like apprenticeship
Yeah.
schemes, you know what I mean, there's a lot we can do.
So below this, so these are the strategic objectives. We've got the vision first of all, and then the strategic objectives take the vision down to that level. Below that, there's a lot of detailed statements that are not in this paper, but
Yeah.
have been developed, and you will see as part of the plan, so that it takes us down into a bit more detail.
Mm.
And then below that is the priorities that you're seeing in here. So you've missed a bit in the middle, because I keep saying the papers need to be shorter, so, but you
Yeah.
will see it when you get the plan in the end, so you'll see how it
Yeah.
translates through, so it is there.
It's
just
hard to
not
see
in
how
the
we
paper.
proactively will operate in this
Yeah.
space by
Yeah,
these statements, but we probably see it when we do.
yeah. But it's work in progress, it's not perfect at the moment, it's really to update you where we are. I'll take those on board so that when we come back with the plan, that we make sure that we've tied it back to all our strategic objectives, and then we've got the detailed kind of processes underneath that, so that it's in there.
Right, and so today is about the next steps and the strategic objectives, but what we're saying is next time when we bring the 24-25 annual plan, or we start working on that.
Yeah.
We bring that level that
Bring
takes
it down to
strategic
that you can see it,
objectives into
yeah.
what that means for what Liverpool's going to do, yeah.
It's because we haven't done it with the exec yet, so so you can't really see what the priorities are against that, so that you can't see what the practical applications of it are. It does make sense, but it's not all in the paper really.
No, thanks, Larissa. Can I see your hand? Over here, no.
Okay, I think we're approving the strategic objectives. And agreeing the next steps.
Yes.
Thank you very much. So your next paper then is, I think it is you still, isn't it? Voluntary commission.
Right, so this is the voluntary sector recommissioning. So this has got quite a history, for a number of reasons, we haven't made the kind of progress that we need to make on concluding it. There's been a lot of work done, there's, steering groups have been set up. We've been linking with CBS quite a lot, and there's a lot of agreement on the lots. But the issues really have been about a lack of dedicated time. Because we commissioned the emotional well-being strategy, a lot of that covers the tier 0-1 kind of stuff that's in the voluntary sector contracts that we've got. And I'm keen, because the feedback from the third sector was that the contracts that they have are too short, they're piecemeal, There's funding sources and they're all trying to do different things. And really, wouldn't it be better if we could pool the budgets that are available through RIF and mental health improvement monies and the commission contracts that we have into one envelope, so that we do that through the RPB mechanism supporting that. And I think that's the right thing to do. So that's why we've taken the mental health lot out of this, so that we can do that in tandem with the other sources of funding that are available. And that maximises the pot to several £1 million. So that makes a lot of sense. And then what we've done is we've met with the sector through CVS and through a range of kind of discussions with the broader sector, not just CVS, and come up with a revised timetable to talk through and that's itemised there to get us to a position where the handover and negotiations are by April 2025. So what I'm also asking, so that is that we roll over the contracts this year, so that we have a revised timetable to April 2025 to do that process. We take out the emotional well-being elements and put that together with the RPB strategy, RPB to implement the strategy. And then the third part of it is really around the financial implications. So. And what the sector's feeding back is that, you know, with inflation running at 10% and 8% this year, that's a real cost to them on relatively small organisations. And could we guarantee the uplift for next year? And it describes in there, it doesn't actually have an effect on us. So it doesn't increase, it doesn't have a cost pressure on us as an organisation, but it does describe how we will manage that. And I think we really need to examine how we're using the third sector more as a way of becoming more efficient as well, because they do things in a slightly different way, but also in a more efficient way. Hence that we've got a 3% kind of efficiency target against it, but it isn't about cutting back, it's about transferring things we do currently in the health board into the third sector. So that's described in the paper as well. So that's broadly where we are with it. So it's really just to note the progress on where we are with recommissioning, the changes that have made and therefore the impact on the implementation programme, the revised process that we're following, and we have run this past the sector, and the timescales, and then the financial commitments are quite important as part of this envelope. So that's broadly where we are with the sector. Thank you. Thoughts, Muriel?
I have a couple of thoughts that I wanted to share. I think it's a good idea to, I mean, I would have liked to see more progress. I think we would have, so I think we need to say that. But I think there are huge merits in getting this right. So I can see why you're proposing to extend, because I think we do need to get it right. I think recognising the financial pressures on the sector is welcomed by partners because they are under huge financial strains. I think that the key for me here is that we've been looking to identify opportunities where the voluntary sector can do things we currently do more cost effectively for a while too. So I think that it's about that insight and assurance about progress and around the type of things and examples of the sorts of things we would like to spin out or want to spin out of the voluntary sector. I think we need to be in that way now. So that would be the push. As an independent member, in terms of assurance.
What I haven't taken you through is the emotional wellbeing strategy, because that just does that. It is making sure, I mean, there will be a statutory component of it, but by and large, the whole of that strategy will be delivered by third sector organisations. That's the aim of it. And that is very much about getting a preventative approach to mental health provision, and working in a more collaborative, getting the third sector to work with us in a more collaborative way, but also in a kind of more dynamic way as well around their own structures, so that they look at kind of partnering up themselves in order to be able to give us a bigger offering. So and so there is some innovation in there. And then the other part of that is really what we're trying to push through the annual plan this year, is to try and get people to think a bit more preventatively, and that's tied back to the work that we're doing on pathways. So and so I'm hoping that things will come out of that we can then start to put into a framework for third sector. But I agree, I think our thinking around the third sector isn't as kind of imaginative as it could be, because I think there's a real value, because they do things in a different way, and if you're really going to engage communities in the way that I've described in the emotional wellbeing strategy, you've got to use the third sector, because they work on a different set of values and whole different set of kind of structures. So I think we are going to have to challenge ourselves around sort of the third sector, and that we
Okay, so yeah, machine is rebooting. Poor old Claire. It's been
that gives me some thinking time.
Claire's fault.
Never happened in business.
Oh.
We'll continue when we reboot it.
Claire, could somebody else join that call? I could have joined it. Seem to you? or-
Yeah. No, it doesn't matter. No. Okay, fine. A good discussion over the voluntary sector. Yeah, no, I can say this. But one of the first board meetings I came to as vice chair, I said, we cannot have this, we cannot keep rolling over these contracts, and we need to think about it properly. And don't think I'm actually going to see it.
We're getting there.
We're getting there, we're getting there. Talk about making that.
It's just such a vibrant sector. I've never worked in a system where the sector is so vibrant. It's
We rock.
Yeah. I don't know where it's that I think it's housing has driven it, actually. All of the innovation around emotional wellbeing has come from the housing sector, actually. I think shelter's done a lot. It's and that's innovated within the sector, within the third sector.
Yes. Apologies for that, slight technical error this end. So nothing has been said in the interim. I think we were talking between, it was Nuria and Nerissa discussing the voluntary sector.
Yeah, and so I think I just don't think if we look at things like connected communities and that policy document, the third sector is crucial to getting that into practice, really. And there's things that we do as a statutory organisation that is not embracing that and changing the way that we deliver those services. So I think we've really got to challenge ourselves when we're going through the GMO process to check if there's things coming through. But around the emotional wellbeing thing, I think we are getting there, so that is very much about sort of thinking very differently about the way that we move into preventative kind of mental health services that are much more about engaging communities in the delivery of their own solutions, I suppose. And that's I think where kind of the third sector ethos is really important. So I think that's probably where we are. I think there's a lot of work to do in terms of making sure that it happens, but I think the thinking is there now, and I'm beginning to sort of move through in through the RPB space as well.
No, Nuria, Angela.
You know, understand where you're coming from with that, Maria. I think it's the bit for me is, you know, what does our demographic look like? You know, what do we really need for our communities? And particularly if you're now moving more services into the community, which is what we are doing, and we're trying to keep the people at home. So the frailty agenda is obviously significant. And how does the third sector complement all of this? What's happening within our strategic objectives? So I think there is, you know, taking the third sector along with us. So, you know, we work very closely with the third sector in virtual boards, you know, a huge partner within all of our board rounds, and there's a real cross-working around what they can offer, and it's significant, particularly around these ongoing needs for patients. So it's got to fit together for me. So it's an understanding what is needed, how does our population look like, and what are the sort of priorities. But you know, there's areas of the homelessness, the frailty, you're talking about mental health, and I think all of these need to be somehow defined in terms of the ask and how that fits around the development of the third sector and the services. And I think then there's another piece for me about the maximising the utilisation and their engagement with the community services, because I don't think that is as uniform and as optimized as it could be.
I mean, I think there's two elements. There's one is about their service delivery, so what we commission them for, but there's also how we work with them in a proper partnership. So not just a contracting arrangement, but a kind of value-based equal partner kind of process, and that starts to really influence the way we think about the delivery of services, and how we engage communities, because they're voluntary kind of organisations coming from within communities. So I think there's two parts to it. It's one about how they influence what we do, and how we work with them in the broader partnership agenda. And the other then is about the service delivery offering that we're contracting and commissioning for them. So, and I don't think they don't chair one of the transformation boards, for example, in the RPD, and they should do. So, you know, it should be one from the local authority, one from health, and one from the third sector. And that would really be an equal partnership. So it's that kind of stuff. It's fundamentally changing the way that they influence us as well.
Their knowledge will really be helpful
Yeah.
for us to understand the population and the communities better.
Yeah.
Thank you.
Can I just make an observation, and that for me, all of this is linked to where we are as a population health organisation
Yeah.
and the links with the population health strategy. And I think that we need to have those discussions now. So when it comes to understanding the community needs, etc., we do have a population health strategy. Let's use that to be the driver of all of this. That's the observation I would like to make. I think there's huge opportunities there. I think the sector is involved there. I think the context there. So it's not just about the regional boards, but it's actually about us driving force behind what the needs of the community are.
Darren?
Yes, thanks. I won't prolong the debate, just some points really. So really welcome this. I think it's been a long time in gestation, but it's doing the right thing. It satisfies the procurement requirements, which are important in terms of governance. I think the key thing here is it stimulates innovation. What we've had in the past is a ring-fenced budget, that effectively a budget of diminishing returns, because we've never CIP'd it, we've never uplifted it, it becomes a stuck thing that really engenders a contractual mechanism, not an innovation mechanism. So what we've agreed is, in principle, if we can commission more voluntary sector services that are currently provided by health, we'll move the budget across and we'll inflate the budget by moving money around the health board. So it incentivizes the growth and the thinking. That's nuanced in the words, but that's really that message. It's Nerissa's budget, sits within her domain, and through the service planning and change, if we can do that, we can grow this and make it really valuable. And then just two other points. One was this 12-month cycle of business doesn't help anybody in terms of sustainable model. So if the procurement model gets us into longer-term partnership, I think that's an absolute
It's crucial.
the other thing is, it's subject to endorsement of this today. We probably need to tell people what our intention is, because there'll be a focus on end of March and potentially running down contracts. So there's a few practicalities that people need to put.
That's right. Thank you, Darren. Keith?
Yeah, so this approach is a welcome approach, and I think picking up on Dan's point, it does allow us to get into a different type, and Nerissa's point as well, we get into a different type of relationship with our third sector partners and through them with our communities, and that's absolutely critical. And particularly if we're going to be into a longer term relationship, not an annualized cycle, but of a 3-year rolling cycle, that is a game changer. But I think the element which Nuria was highlighting was we need to be clear about why we're entering into partnership with the third sector. And it's not just about shifting stuff that we do onto somebody else. It's actually about doing things very differently. And Naria started to talk about the different culture and different behaviours of the third sector, but that we need to be looking at, well, what opportunities do those different behaviours and cultures and attitudes and the different worldview, what opportunities do they release for us in relation, in service to Naria's point, which is we need to be becoming an organisation which is interested in generating health and preserving it, not just patching up sick people.
Exactly.
And Keith's last point actually for me reinforces Andrew's point.
Yeah.
Which is you have to start from knowing what the demographic looks like so that that can inform the way forward. But I think we should also be mindful of Darren's point about the approach to procurement. Because what we can't have is a situation where we get into in 24-25 where we're having to wind down contracts because we're falling foul of the new national policy.
I think what is different about the conversation we're having now to where we started in this some years ago is it started from a procurement perspective.
Oh, okay.
And now procurement has come in as a yes, and it needs to fulfill procurement rules, which of course it does. But what we're now getting is the benefits that in terms of thinking and approaches to prevention and different ways of working that were not present when we started this conversation. So even though it is frustrating that it's taken so long, I think we have made quite considerable progress. Yeah, good. So we're being asked to approve the revised process, approve the rolling over of existing SLAs for 24-25, and approve the revised timescales and the financial commitments for 24-25. Are we happy to do that? Excellent. Thank you very much indeed. Oh, sorry, Annalise.
It's just, and maybe naivety, but the list doesn't mention housing and the third sector's involvement in housing. And let's face it, some of the residents in the area are living in substandard housing, which has an effect on health. There have been reported cases of children who had terrible outcomes as a result of mold and traffic, etc. And I just wondered whether that was something, if we're talking about population health, part of it is having a suitable housing in order to cope with the kind of health that they contend with.
I mean, these are, I think it's been driven by the kind of the health contracts, but we are linking quite a bit to housing, aren't we? It's
RPB.
RPP, isn't it?
I have to declare an interest. I sit in Shelter Cymru, but you're absolutely right, and it is part of the RPP. So there is a housing element to the RPP, and there is a housing element.
And there's quite a bit of capital. We've got very tight kind of criteria.
There is some merit in the point that she's made about crossing the dots and making sure, and I think that goes back to understanding what we need from this, which is where there's an ongoing conversation, because we do know the needs in our community, so we know who are the most deprived. We've done that, and we have that data. We know that we've got huge disadvantages in our communities. We know that if you end up in one of those houses, you start your life in one of them, then your likelihoods of having good health outcomes are really minimized over time. So I think that analysis is there. I think it's just about where is the innovation, what do we need from our point of view, and how can we work better together. And there's lots of how it links in with all of the different regional arrangements that are happening.
So there is the capital in RPB's got incredibly tight criteria on housing, and provision of kind of innovative housing solutions is one of the key ones linked in to the capital strategy. So that is in there, but it's not specific to what we're doing here. So it will come through the RPB, right?
Yeah. Okay. I think there are more discussions to have on this, and we need to think about where we take this. But I think for today, I need to move on. I'd like to welcome Kerry Gimlett and Amit Sanu for the next item, which is our agenda item 3.2, which is to agree the business case for Singleton Theatres. Deb, I think we'll leave you on this.
Yes, please, thank you, Chair. So, the case itself, you can see the paper is self-explanatory. It's probably the third chunk of our clinical services plan, coming alongside the consolidation of NMSR at Morriston and the additional theatre complex in East Albert. This is icing on the cake, if you like, that gives us an additional capacity that we would need in Singleton to consolidate on as much of our elective work away from the Morriston site as possible. The paper just sets out the options available to us and the preferred option. And you can see there's a capital and a revenue option included, with the capital option being the preferred option at the moment. That comes in at just shy of £23 million from a capital perspective, with a revenue tag of 30 million on top. So it gives us the additional capacity that we need to eat into the backlogs that we've still got. Key to that is the hysteroscopy suite, particularly where we don't have a designated hysteroscopy suite, and we really are an outlier as a health board for not having a fit for purpose facility for that. It gives us the options for moving theatres out of Morriston, decommissioning some of those to refurbish, because our theatre suite in Morriston is very old and in dire need of refurbishment. And it also gives us that extra capacity we need when we want to branch out further into the regional space, because it really does give us the capacity we need in the place that we need it to manage the patients in the way that we do. So I'll stop there from an introduction perspective, Chair, if that's okay.
Yeah.
Kerry and Meath are on to give us the expert feedback for any questions that are about as well.
Great, thank you very much. And we've had various briefings on this over the past months, so I know there are questions from independent members. Miriam?
I think it's about assurances around any optimism bias that has been factored in. In particular, you've mentioned the revenue implications. It's also around assumptions on the substantive recruitment element of this, being on the optimistic side, given where we are at. And I think explicitly it says that some support costs have not been factored in. So I just wanted to find out more about what that meant. The key for me, I think, is the assurance that we're confident that this is affordable, given the revenue pressures that we have, and that there won't be any surprises when it comes to the implementation side of things. Because we have discussed this in length. So I think for me, that's where I'm personally at.
Shall I take Rena
Yeah,
then,
Chair,
and then,
yeah,
yep,
fine.
yep.
I was wondering what, I mean, I'm not doubting in some ways that we, you know, in our, given we've talked about our estate strategy earlier, that we probably do need these. But I'm just wondering, in terms of demand capacity issues, have we completely worked through that we will need this capacity into the future? You know, in the sense that I suppose our worry is that the finances are getting tighter. So we want to make sure that what we are using our finances for is actually to meet the demand that we know that's coming through, and that it will be fully utilised.
Okay, shall I respond there?
Yeah, please.
Lovely, thanks. Can I move backwards, Mary, if that's okay? So just focusing on Rita's questions in the first place. The demand capacity we've done at the moment is based on what we currently know. Obviously, we know the timeline for this will take us to probably mid-2025 by the time it's in place, if it goes through as we anticipate it will. That demand capacity will change. I think what this does give us, though, is the flexibility to manage our capacity in the best way. And if we need to reduce some of that capacity that we've got available, then we've got an option of reducing that on the Morriston site, because that's where the lion's share of our theatre suites are. But we know we can't maximise the use of those theatre suites because we haven't got the bed contingency to match. And if we focused only on using the theatres in Morriston, then we'd still be in that chicken and egg bit of how do we manage our elective against an emergency. So I think it fully supports the health board strategy to decouple emergency and elective, and we can't do that without this additional capacity in Singleton. I think since we started the conversation around the additional theatre case, the regional question is coming up on the agenda for Welsh Government. This puts us in an ideal ballpark to work in across a regional footprint and move things across the footprint and making Singleton that real sense of excellence for the other surgical services that we similarly in the way that we've done in Leith for urology and orthopaedics. On Nuria's point then, so the revenue tag for this is based on what we looked at for Neath Port Albert. So on the holistic bit, it's probably looking at like for likes of 3 theatres, so 3 additional theatres from a staffing resource. We've looked at how that would work if we had to recruit them fully. It has been pushed quite significantly, I think, over the last month since this business case was written. It has moved around a bit, so we've taken stuff out, we've put stuff back in. Because this is the outline business case, that could change. So that revenue tag, I don't think it won't grow, but it could reduce when we look at actually what do we need and where do we get the resource and what do we put in those theatres when it's available. So I think it's a good line in the sand as an indication of what the revenue tag will be, but it will then depend on what the demand capacity looks like. Then it could be that we decommission theatres in Morriston, there's an opportunity to move staff from Morriston, or we move things around as a region. So I think it's as good as it can be at this point, but bear in mind it is a moving feast.
Answer you?
Aaron?
I'm just going to give a bit on the money really to complement Deb's really clear articulation. So it's not money we've got, we're asking for more money.
Yeah.
This isn't about displacing other investments in the board, we're asking for the capital and the revenue.
Yeah.
And you know, expect that to be challenging, but that's the nature of this. It's not a fit into the plan in the sense of we're making local choices. On the granularity of the costing, I'm happy to share the detail, but we've gone from digital teams through the cleaning teams through the clinical teams. We've got a full list of exactly what the nature of this expansion would be. And I think notwithstanding the potential variability of the future in terms of regional, what these give us, as well as a strategic fit in terms of the clinical service plan, is the opportunity to change the air handling in the 6 theatres we've got at Singleton, because that's overdue. If when we get to the point that we've got a sustainable waiting time position, we'll reflect on the day surgery unit across the road and whether we need to continue with that. Because once we've got a new theatre, the other 2 theatres were 20 years old and they were modular and would probably require investment as well. So it's a really helpful strategic piece, in terms of waiting list reduction, but also then with the flexibility of the site and be able to concentrate again back onto the main building. Notwithstanding, there will be variables and there will be a strong regional sense here. We may choose a slightly different blend of that, but 3 seemed like an optimal number. We've spent the last 3 to 4 months trying to kick the revenue into shape, so it is the board to be assured that it's been through with a microscope and all the sort of factors.
Great, thank you very much. Steve?
Yeah, Cynthia, I was going to ask if option 3 is our preferred. When we approach Welsh Government, will we say prefer option 3, but option 4 is also doable?
Yeah.
Yeah. So you'd like us to approve both of them, but
Yeah.
in that order?
That's a good point, thanks Steve. Yeah.
Thanks, Steve. Jackie?
Yeah, just a kind of practical question. With some of the surgeries moving to Neath Talbot, orthopedic, spinal and neurology, I was just wondering, there's no HD or ITU in Neath Talbot? Is that planned for, or is that, because these are slightly more major surgeries than what has historically been performed at Neath Talbot?
Yeah, so the clinical model, so Neath Talbot, we've never looked at putting HDU facilities in Neath. That's why we've got a prioritisation process for the patients and the categorisation of surgery that can be undertaken in Neath Talbot. And for orthopaedics, we know most of those, when we work through the backlog, we can manage those quite safely in Neath Talbot. We are trying to bolster the Neath Talbot model with a transfer service to make sure we've got the facilities to move patients quickly should any patient need transfer into Morriston Hospital. We've got that at the moment, Jackie, 8 till 8. We're looking to extend that to 2 AM just to give that added assurance, and that would then also be available for Singleton. Whereas we know Singleton, we've got enhanced care unit at Singleton, and we've got an on-call anaesthetic team and a theatre team in Singleton to manage the patients more safely. That is acknowledged, though some patients will never move out of Morriston, which is why we need to keep an elective element at Morriston. So those really comorbid patients or the very complex surgeries that still have to be undertaken at Morriston. So what we're trying to is having those building blocks really to take as much away from Morriston as we can, so that only patients can absolutely only be done in Morriston are done there.
Thank you. I'm going to bring Richard in at the end. Just before that, I just want to ask quite a detailed point. The calculations on the number of cases are based on 50 weeks a year.
Yes.
Is that actually doable? With theatre downtime and things?
Yeah, that's why the revenue reflects staff in the theatres 50 weeks a year.
Yeah.
Bearing in mind that most of the surgical staff in the theatres probably maximum 42 weeks a year, but then there's an element of backfill.
Okay.
We're looking at those teams. So the revenue is based on the theatre teams being available 50 weeks a year.
Thanks. Richard?
Yeah, so I think Deb's really covered off the point, which was that what this gives us the flexibility is of a low acuity unit at Neath, medium with backup of enhanced care at Singleton, and then obviously higher care and intensive care at Morriston. One of the challenges that we've got, particularly in those very long waiting patients at the minute that we talked about this morning on the waiting list, are the key for those patients who need their surgery to be done in a location where they're co-located with an HDU ITU, and everybody's fighting for those slots in Morriston. What this does, it just allows us to much more flexibility to operate on people in an appropriate location that's appropriate to their coexisting medical conditions or the degree of significance of their surgery. And the other point I was going to make was, I think Darren made it, which is our concern about the fabric of particularly our theatres at Morriston, both in terms of airflow, some of the stuff which is relatively easy to address, through to some of the more fundamental issues about the roof at Morriston, and it gives us a backup in terms of our ability to maintain business continuity in circumstances. So I think it's just what we need.
Great. Okay. What comes through actually quite clearly is the strategic aspect of this actually, and the changing for the future and how important it is as part of that 3-site model. Good. Okay. So I'm going to ask the board. I can't see any more hands. So we are being asked to approve this business case. Hang on. Is it just to approve the business case? Is there anything else? Yeah, no, we're just being asked to approve this business case for submission to Welsh Government with the associated capital ask of 22.8 million and recurring operational revenue of 13.1 million. Yeah, great. Thank you very much. Thank you, Kerry. Good to see you.
Thanks, Kerry.
Okay, good. So we're now going to move to section 4, and we're now going to follow the agenda more closely in order. So we've got part 4, people and digital, and we start with the key issues report from Workforce and Digital Committee, which Nuria chaired for the last time.
The report is there for noting. I'm going to start by alerting you that the committee was informed that there was no financial plan in place for overseas recruitment beyond this financial year. I would also like to assure you that we are driving down agency costs and increasing the quality and safety and reducing our time to hire from May to September. We have appointed 400 Band 5 nurses, 250 healthcare workers, and 190 new medical appointments. We continue to undertake deep dives into sickness absences in areas which have had the biggest in-month hikes. And I would also like to alert you of the business continuity incident that took place in April and give you the assurance the committee was given as to the plans and procedures in place to address such incidents. I would also like to advise you of the progress being made in relation to the Anti-Racist Wales Employment Action Plan contained in the report and the approval of the subject access requests policies. That was your.
Thank you.
So everything. But I would like to bring in Matt and not there. Is there in the room?
Debbie, she's moving down that side.
Just in case there's anything that I've missed that you would like to, and of course, other committee. I think it's just you and me, Jean.
So you make the point about the our plans for nurse recruitment, and I'm going to bring Gareth in actually around that.
Do you know, we've had a bit of a junction, haven't we, with our nurse recruitment. We had a spectacular couple of years in terms of filling vacancies.
Yeah.
That's either from a streamlining or from our international recruits who've been brilliant. But it's got us to a point really, thinking, well, what is it that we need next year? We don't need 300, which was our original 350 actually, which was our original figure, because we were almost fully established. So the aim is that we'd have an ongoing, maybe 10 per cohort, international nurses, but then focus on areas like neonatal, like maternity, like mental health and the like there. So we can build up our numbers to enable us to get staff into those more sort of specialist areas. And there are nurses available is the feedback there. From our unregistered position, we know we've done loads of work and I think actually building on what the Band 4 healthcare support worker and support staff can do is really important for us moving forward. And just building on the successes and to advise board, we've been asked by 2 health boards to manage their OSCE process and have some the income attached to that. So the success around that's been really good, but I think we are in a bit of a line now and say, well, what does next year look like? And that goes to the point about sort of the plan being developed there. And Darren and I are in conversation about what that looks like financially and what we can support moving forward. So it's a good news story there, really.
But it is under, because that was the concern of IAMS, wasn't it? It is under active consideration. Good.
And just to add to what Gareth has said, I'm pleased that our business case to expand the central resourcing team was approved, and it enables us to do some focused work around the hard to recruit areas like maternity, neonatal, mental health. So that's our approach for next year, going out and doing bespoke focused pieces of work. And also we're becoming more sophisticated with our workforce planning. And that will, our workforce planner is actually in the room. And that will enable us again to be specific and focused in terms of how we deploy our resource better next year.
Thank you. Darren?
Yes, just the numbers, there's 3.9 million in the plan this year for obviously this recruitment. We've added a bit of that back because it was cheaper than we thought. That money is recurrent in the financial planning outlook at the moment. Okay. So if there is, I guess the point I was trying to make is a balanced, sustainable solution would be very welcome from a service perspective, recruitment perspective. If it was less than 3.9, that's a contribution to the bottom line that we weren't anticipating. So somewhere in there is a sweet spot of money back into the plan and doing the right thing.
Right, I think.
It's not 3.8. It's got a one in front of it.
No, okay, thank you. Thank you very much, Nero. Any other, oh, sorry, Jean.
We did also have a conversation in committee about metrics and reporting and use of data.
Yeah.
And I had a subsequent meeting with some of the team to discuss data, just to try and get some sense around what system speaks to what system and why we were behind in reporting some of the metrics, because not having up-to-date metrics in workforce management and indeed workforce planning is critical to making sure that our strategy works in the future. So we had a very useful, I found it very useful, I hope the team did too, discussion on data and systems. And I think there's a lot of opportunity moving forward to change that or to update the recency of reporting statistics into that committee. So that's something that we're going to have a look at over time as well.
Great, that's good, thank you. Very good indeed. All right, so we will now move on to the next item, which is the Nurse Staffing Wales Act, which is you, Gareth.
Thank you, Chair, and this is for noting and assurance. And the report provides the board with the annual mandatory assessment of the Nurse Staffing Act level, which confirms the Health Board's compliant with Nurse Staffing Act Wales 2016. But can I draw your attention to the key reporting requirements contained within the statute? And these are that the board receives an annual mandatory presentation of the nurse staffing levels, which have been calculated for all Section 25B wards. These are our acute medical and surgical wards. The board receives a non-statutory annual assurance report in May each year. That went through our Workforce and OD committee this year, who did that on our behalf. And the paper introduces the annual assurance report for the reported period for the 1st of October 22 to the 30th of September 23. The financial impact is a required investment of about 21,000. This has been taken by a management board, and that's been agreed and supported there. So that will be provided to Morrison Service Delivery Group. And the details of all the assessments are contained within the report, and you'll see by Appendix 1 and 2 that there's quite a science behind this and quite a bit of information there. And again, the establishments were agreed at management board. There's a section within the report as well, and it builds on the last discussion about recruitment, nursing workforce, and I draw your attention to draft 1 and 2 in particular, which shows the reduction in agency spend in Morrison on the back of us recruiting fully to our establishments there, which is a major step forward. The other area, and it's the more important area, we know that having fully established wards, fully established units, really does enhance the care that we provide there. And while we're still in that transitionary period, having lots of new nurses in particular, you know, the benefit that's going to have on us, I believe will be enormous. So we can't pick up foot with the accelerator at all in terms of maintaining our vacancy fill rate for next year, and then really recognise, you know, the financially challenged NHS that we have, that really establishing well does have major benefits financially also. So the report this year for, sorry, I'm getting ahead of myself, to note the changes from January to August, to note the changes in the funded establishment and that we've got to invest for the 21,000. And there's a final one there about the reporting limitations, and it goes back to a question that Jackie has asked me probably 7 times now over 5 years about having immediate information about numbers of staff on wards. We're nearly there. I've been saying that for 3 years. We're nearly there, but we are nearly there now. The Safe Care tool that we're using to oversee our rosters. There's an always fix in terms of a reporting requirement with that, and once we get that, we can provide that information.
And that will link to bit also to Jean's point about.
Jean's point also.
Yeah, excellent. Thank you. Thank you, Gareth. Jackie.
He saw me raise my hand. He knew, but I'm going to ask a different question as well. And I was just thinking we've been incredibly successful at recruiting these overseas nurses, but the life change for these people is phenomenal. And I'm just wondering, what are we doing as a health board in terms of that ongoing pastoral support, so that they feel, you know, some of that stress is taken away, and then we're going to retain these nurses.
Yeah, and maybe I can get there here as well once we go. Now, all our international nurses are obviously making the relationship with us before they arrive in Wales. You know, we have a really good process in terms of preempting their arrival, supporting them in terms of when they arrive, providing accommodation, providing finances up front to see them over the first couple of weeks here, and really just recognise that, you know, I always use the adage, if my kids are going to the other side of the world, you don't want someone to put their arm around them, and we really feel that, you know, these are making such major life changes for them and their families, that's central to what we need to do. Now the challenge is as they then get into living in Wales, they are confronted by the same challenges that everyone has around cost of living, around rents is a challenge, getting to work and the like there. So the ongoing pastoral support is central to understanding that, but then recognising that we've got networks in place that they can link into and get that support there. So it's a major change. And I don't know, you know, if you've seen our training hub here. We've got a new cohort start actually last Monday, and really the warmth and the enthusiasm that they bring into Swansea Bay is changing us. I really believe, and that's not to decry our staff, it really isn't, you know, but there's a different strand there. So a really important question, Jackie, and I don't think we've nailed the longer term support, but the longer term is the challenge, I think, that everyone has here. Deb, is there anything to add?
Yeah, I just want to say in terms of the transitioning, that's a real biggie. For us, one thing we are doing is those cultural conversations just to really settle people into Wales. We've got a global majority, we call it, network staff network group, again, so that then people have buddying and peer support. And I think the most important thing that we do is treat recognising people with different experience.
Yeah.
They come as experienced nurses, and we support that. We've now brought in some coaching and mentoring support, and actually we've now seen some more promotions from our international nurses, which is great. And I'm sure many of you would have seen on social media, we had 3 that went to the palace, Buckingham Palace, last week and got to shake hands with the King. So they were really, really excited about that.
That's good. It's good to hear we're getting promotions as well, because that was something that was concerning us, wasn't it? Yeah.
It's a key cultural challenge, and it seems a bit obtuse talking about them, and I'm pleased to take it in that context. But the confidence to come and work in our system, the confidence to know that their skills are as good as anyone's, and even going through interviews. Even the challenge of sitting in front of someone and being interviewed. So a lot of supportive work as well in terms of career development. And the nursing academy that we're developing is about developing them as individuals to really get there. And it would be great, wouldn't it, if we had a real run on international nurses being maintenance, being directors of nursing, you know, it would be brilliant. It would be brilliant. And my final point, I think it links into the diaspora discussion earlier.
Yes, it does.
And really the cultural norm to an international nurse is where working in that way is the norm. So us allowing them to work that way in terms of how we support them flexibly with their off-duty and rotas and so on is really important. So I could talk all day now, so that's it.
No, thank you, Gareth. Nuria.
I'm an overseas person myself, so wrapping your arms around me would be really good, Gareth. I think that as an independent member, you don't just take for face value what your executives say, you actually try and find out for yourself and triangulate the information that happens outside this boardroom. And what I would like to say is that I have met a lot of overseas nurses, and the feedback that I've had and recognize some of, and it was just, you know, it was just a delight to be able to recognize some of the programs that we've heard of in Workforce and OD, and actually them sharing their experiences, which so far have all been very positive, although I'm sure they all want promotions and they keep telling us this, but I think they've been really positive. So I just wanted to give that feedback to the board, because that's often, it's not just about the data of what you bring to us or those conversations, so those conversations that we actually have outside the board, and just give a flavour of that.
Okay, Darren.
Just a brief point on the money, because the money is relatively modest on this occasion, but in the past we've had, as part of the broad assessments, £1 million investments and those sorts of things. So it's more about the principle of when these adjustments are appropriately made, the money comes from a central pot, or is a challenge to the financial plan. If there's ever a step down in acuity, then the money comes back to the central pot. So it's just that be clear that that's the mechanism we've deployed here. Because if this was £1 million, we'd be having a much more difficult discussion. And the fact is 21,000. But the principle remains the same regardless of the scale of the investment, which we've backed and have always backed in terms of the financial plan.
Thank you, and thank you for bringing us back to the Nurse Staffing Act as well, because we took a slight detour, an important detour, but I think it was that it's important to come back to this. Richard.
Just on a broader thing about staffing, even with the best plans, there'll be occasions when we're short on a shift. And so and we're conscious of the amount of money that we spend on agency. We're conscious that when we ask staff what we offer at bank shifts, why they don't take us up more, one of the frustrations is we don't often pay them for several, I was going to say several days, it's often for several weeks. It doesn't appear in their bank account, and that's a disincentive. We know that if we have our own staff take on an additional shift as bank rather than an agency, that's better all round. It's better for the staff who are working with them. It's a colleague who's working with them. It's better for patients, better for quality, better for safety. You've got a known member of staff in an environment that they know, in a system where they're familiar with the systems and processes. So in the next couple of weeks, Debbie, we're bringing in something called Wage Stream, which has been used in other health boards, which will mean that people will have access to the money when there's additional shifts sooner. And we're hoping again that would be another incentive for people to take on additional shifts and have even less reliance on agency staff, then we'll have an increase in the bank uptake.
Good. Excellent. Thank you very much, Gareth. So we're now going to move to item 4.3, which is the people strategy. Over to you, Debbie.
So I am really pleased to present this 5-year people strategy to the board, which has been co-created by staff. From our feedback from our big conversation as well as trade union partners. So just to give assurance, sitting behind this is a really detailed equality impact assessment, which we haven't included, but we can just make sure it's in the resource pack for you to have access to. The aim of the strategy is to steer our direction of travel for the next 5 years, and it will undergird the delivery of the health board's vision document. You'll see from the document, the strategy is divided into 7 themes, or 7 strategic themes, which are linked to the national documents, all the national documents that relate to workforce. So I know members have read the document, so I won't go into the details. So I'll wait to receive questions. But I just want to end by saying that we have undertaken some significant engagement on the document. An early draft went to Workforce and OD, and independent members were able to give us some steer around how we shape the document. and it has been approved by management. So I've got members of my team who were key to driving it, particularly Sharon here. So if Sharon, would you like to just say?
Welcome, Sharon. Just thank you, and I should say Simone has been instrumental to developing the strategy, and obviously Simone's part of my team. Just 2 points really I want to make in terms of the strategy, and I mentioned this at management board. One is it's a really important document because it's about the workforce, and really it's going to underpin all your plans, all the health board's plans for the next 5 years, and that is really, really critical. And I think the other thing I just wanted to say, you know, we've taken Arissa's lead here. We're not going to translate all of our actions into GMOs. So we're going to be developing our own performance management framework to hold ourselves to account really year on year as we work through the strategy, going through our own governance processes, going through to Workforce, OD and Digital Committee, and then ultimately up to the board as well.
Thank you. Thank you very much. So before I open it up for questions, I mean, I'm delighted to see this. I mean, Debbie and I have discussed this. We've had so many really great initiatives going through the organisation, but to see it coming together as a 5-year strategy is a really, really important milestone. So I really welcome this, and it's a good document. So thoughts, questions from independent members? Rena.
Yeah, I'm really pleased to see it as well, because we've talked about it for a little while, and it's great that it's now in here and we can use it all. The bit that I've always been worried about within the organisation, and it's sort of has come out in a couple of the risk register issues, is our workforce planning and of the risks in certain areas where perhaps we haven't planned effectively, and then somebody leaves, somebody retires, and we've left, you know, struggling. So in a way, can you perhaps explain a little bit more how you see that coming through in this, in terms of how in particular services we will be doing this workforce planning and actually identifying what are likely to be gaps in 2 years' time, 3 years' time, or whatever, and actually thinking that through in advance so we don't end up with a problem.
I mean, it's a good point, and I suppose it covers 2 particular areas, I suppose, in my mind, and I may bring Simone in a second. One of the themes is about being well planned. We called it workforce planning supply, but our staff psychologists really didn't like that comment, so we came up with a simpler term. And we have an aspiration, and certainly, I mean, my workforce planning team is small, it's perfectly formed, but we also work with our workforce BPs as well, and business partners, to develop the whole workforce planning offer then for the organisation. And that clearly is part of the challenge, is to make sure that we're able to plan and forecast and plan forward to identify those sorts of gaps. The particular point I think that you're also raising, Rena, is around talent management and about succession planning, and that is firmly embedded in the people strategy as well. Making sure that where we've got very specialised areas, that we're thinking forward and forecasting then how we're going to replace those skills going forward. But it's a very good point.
And I think just to add to that, Dean's point talks to it precisely in terms of our data. We need to improve on our data. It's quite great that we now have an integrated committee with digital that will enable us to improve our sophistication around that, our approach to data, information, and using our information appropriately. So there is more for us to do in this area. It's quite a journey, but we think that, you know, with this strategy, we're starting and we're working together with Matt's team around.
Yeah, Catherine, please do. Yeah.
One of the things in an organisation I worked in some years ago, we, as part of the annual appraisal, we discussed the future and what your plans were in your particular role, and whether you were looking to for the training promotion or whether you were looking around. And in some ways it was quite an open conversation, but sometimes it was obvious there was no role for you. If you wanted to work the ladder in that organisation, you were going to have to leave. So do we do that routinely as part of our appraisals?
Yes, we do have talent conversations. We started, I think it was last year or about 18 months ago, we started tier 1s and 2s, and we developed the framework, the talent and succession planning framework, to enable line managers to have that conversation. We're now using that framework further down the line. We've got it available for staff. We don't mandate it, but therefore line managers to use. We're actually piloting it quite significantly with the nurses. And it's part of the Nursing Academy's approach to identify people to go on the program. So we need to, we've got it available, we've developed it. Actually, that's one of the reasons why we've had a number of movements in terms of our own leadership through our talent management and succession planning program.
Thank you very much, Rena. And Louise.
I like the way it's set out, and it's certainly impactful, and I just wonder how it will be promulgated to staff so that they can see that there are plans for them. They can identify almost themselves in one of the themes or all of the themes, so that they realise that it is worth staying at Swansea as long as they have the right conversations. How will we be assured that that's what's going to happen? Because it's a great piece of work, but only if the staff are on board with what you've said.
Actually, the staff have shaped and influenced the document, because there was a month where we just engaged with the whole of the workforce, so they've already seen it and helped us shape that. One thing we haven't mentioned really is that during the month of December, we're working with an external company to make it look visually more appealing, and then we're going to launch it through a variety of different means then in January. So that staff will, and we've also included a glossary as well, because we're conscious we use lots of management speak, try to keep the language as simple as possible, but just to help staff and really be able to understand then exactly what we're saying.
And is it something that will be used for the PADRs too?
Yes, I suppose so. We haven't really thought about it that way, but I think that's something we can do in terms of our underpinning action plan, which we haven't developed as yet.
Thanks. Thank you. Thanks, Anne-Louise. I've got Keith and then Jean.
Really welcome the strategy and echo what's been said about how well set out it is. With my Swansea University hat on, I just wanted to thank the Health Board for all the training opportunities it affords for our students in a range of disciplines, from nursing, medicine, allied health professionals, pharmacy, everything you can think of. And that role is really important, and staff need to be developed to support that role. I'd argue it's an important piece of business in terms of the future workforce. You've kind of referenced HEIW. I wonder if it would be appropriate to recognise sort of higher education partners as well in the strategy, so that that's kind of formalised and recognised as important business for the Health Board.
We can do that because we do work quite closely with the university, as you know. So yeah, we can make sure we are explicit around that.
Yeah, thanks. Thank you, Debbie. I've got Jean, then Nuria.
And building on Keith's point, I think theme 2 of that attract and recruit, and dovetailing to careers. I think that's a natural pathway for the two to meet under that. I guess my observations are 3. I have 3. One is around the international recruitment, which I think we've already discussed, and the importance of, as a people strategy moving forward, if that is a cornerstone of our strategy, I think there may be an opportunity to highlight that, which is probably coming out in the next step down, the operational elements, but maybe hasn't been fully drawn out in this piece of work. Because I like the work, I think it's easy to understand and the flow is good too. Theme 3 and 4 for me, which most of you will have guessed, I probably would have some thoughts on that. In terms of this report, I think it highlights what we have to do for our people in getting them digitally ready, and in us utilising it for workforce planning and better business intelligence provision. But one of the things I think we also need perhaps to think about in the operational elements is, how do you dovetail that into not just getting our people digitally aware and ready, but enhancing digital systems that dovetail into the delivery of that business intelligence, because I don't think that's necessarily pulled out either. So those are my 3 observations, Chair.
Thank you, Jean. Did you want to come back on? Oh, yeah, Mark.
I guess right in the middle of that is user-centered design, isn't it? With, you know, solutions that we need to build and solutions we have that we need to take further forward. It's about making sure that the people who are using them, who are the real experts, are meeting the way on what they do. We get that continuous loop, that continuous feedback of how we improve.
Yeah.
And you know, that's definitely at the heart of what we try and do, but you know, together now we improve our.
I think one of the things we should say is well done to the department for getting out the stats they get out, because the complexity of one system not speaking to another, different platform, it's just a, considering the amount of staff we have and the complexity of the departments, etc., you need a degree in science and analysis, I think, to work in that department.
Thanks, Jean. Nuria.
On that vein, that's one of the things that I wanted on the record to have, is my appreciation for all the work that Deb has done. We've all been eager to get it. It's here, we received it, and it's a great starting point. So thank you very much for that. And I know Tom would want to share that with the board.
Yeah.
And I think that we've had a long discussion in Workforce and OD about metrics and how we can hold your feet to the fire. And I think that's a conversation that we need to continue having. So that's the missing link for me. There is also something about, and there's lots of questions I could ask you about, you know, specific questions of quality, what does that look like, etc., which we can have those discussions in Workforce and OD around. There is a specific element for me about the importance of this strategy, looking beyond what we're trying to set ourselves here to where we are as a organisation in terms of our population health agenda, and us as an anchor institution. And I think that what I would like to see is just a hook and a link into how that works, because for me there's a huge opportunity to not just look at us internally, but actually to look at what Keith has just mentioned, you know, the work that we do with others and what does that look like, and hook it to the population health strategy to make that stronger.
Really, it should be a golden thread, really, and that's what we've tried to do in terms of, you know, linking it back to our role as an anchor organisation in an anchor system. We might need to think about how we can make that more visible.
Yeah.
Richard.
There's also the link. You covered the big conversation and the fact that that was, you know, at the heart of this, and a big conversation clearly led on then to the development of the vision, a high quality organisation. So I think that's a golden thread that runs through the people strategy and a whole host of other things that we're doing as well, including population health in terms of, you know, clearly articulating what that longer term vision is.
Yeah, and there is, I can't remember the exact timescales, but there is a plan to sort of get that sort of landed, so to speak. So we've got the vision, we've got people strategy, we've got all the strategies that we have developed so that they sit together under the umbrella of the health board vision, the 10-year vision, which will be good. Excellent. Well, thank you very much. It's a great strategy, very welcome, and we'll promote a lot more discussions as we go forward. Thank you very much, and Sharon, thank you, and your team. For we know these strategies don't just appear. There's an awful lot of work that goes behind them, especially when they are short and clear, as this one is. So thank you. Okay, right. So we've now got item 4.4, which is the update on the establishment of an equality, diversity and inclusion group and integrated anti-racist Wales action plan. Richard.
Yeah, so this item's for noting. I think I'd describe it as an update in general terms around equality, diversity and belonging in the work that we're doing. I think it highlights the building blocks that we've been putting in place and some of the early progress that's been made as well as identifying some of the very clear next steps that we need to take. I mean, hot on the heels of the previous conversation, where we finished off around the vision, I think it's important to flag up that the work that's highlighted in this report is consistent with the vision and what we want to achieve, and that is relating to the patient-centred approach. It means meeting the needs of different groups, and in doing so, recognising intersectionality, which is an important sort of concept when an individual can be from more than one protected characteristic group. So it's really about treating individuals as individuals and having that person-centred approach. One of the building blocks we put in place is the establishment of a strategic equality, diversity and belonging group. So that met first in April 23, so April this year. It consists of internal and external stakeholders because it's sort of fuzzy space in terms of equality, diversity and belonging between the internal and the external. The group has overseen and contributed to our work on the Anti-Racism Action Plan and the LGBTQ+ Action Plan. The next steps, which I think is a really important next step, includes the updating of our process around the equality impact assessment. And I think that will enable us to really sort of mainstream considerations in this area and make sure that all of our decisions and the discussions that we have are mindful of the equality, diversity and belonging agenda. I'd just like to focus particularly on the LGBTQ+ action plan and just relate a personal experience of that in the sense of I went to a workshop in Town Hill and the methodology that was adopted and that we're approaching with this piece of work is around engaging directly with individuals and really spending time to understand their needs and their concerns. We had a workshop in Town Hill with the trans community and it was really, really effective and good. And we got lots of rich feedback from the individuals in attendance about what it feels like from their perspective to receive services from the health board. So that was one part of the LGBTQ+ action plan development. The plan is being finalised in the next month and will come through the approvals processes in early in the new year. Well, one of the things that's come from that and from the other work that we've been doing as well is noticing that as well as treating individuals as individuals, we're also identifying themes as well. One of them is around picking out some common themes, for instance, recording patient characteristics. So helpfully, we're identifying these themes that crop up across different protected characteristics groups, and then we're able to raise them. So on the recording patient characteristics, we're working with Matt and his team to escalate these in an all Wales level because it relates to all Wales digital systems. So a challenge there, but I think it's really important we recognise that what we need to do there. Just in terms of a couple of next steps before I finish. So next step, we're looking at the Disability Action Plan in the new year, and we'll be adopting a similar approach to the LGBTQ+ action plan there in terms of gathering the views of individuals with lived experiences. And then the last thing I want to mention is around the stakeholder reference group, where that group provides scrutiny and advice to the health board. And I think it's really important there that we've got members from protected characteristics, but also from a broader range of groups as well. For instance, those involved in substance misuse. So there's a rich input into that particular discussion and debate.
Great, thank you. Questions, thoughts? Steve?
Yeah. So a couple of things, Richard. The Human Rights City, Swansea, I know all about that. I signed the charter, in fact. But does Neathcote Talbot have anything equivalent? And if so, should we incorporate their thoughts into what we're doing?
I don't know, Steve, but we'll.
I don't know either, but yeah, but we should look at it. Yeah. And 3.7, stakeholder reference group we just talked about. It says elected representative. I don't know, but who is the electorate? For my benefit, I don't know who does the electing. And it's an advisory group to the board, but in what way do we get their advice? Do they write reports to us? Do they turn up sometimes? I don't know how it works.
So on the membership, we'll get you the detail on how they're contacted. In terms of the governance arrangements.
Yeah, that's something we're looking to develop in terms of supports. I think we've gone through a period where the chair and the vice chair resigned at the same time. So we've been building that group back up now and providing that support. But they are they're not members of staff that are on that group.
The other thing in terms of that, in terms of the chair of that group, we've recognised that it's a time commitment. It's not easy, and therefore we're introducing a stipend for the chair so that we can actually get somebody and be on a more sustainable footing going forwards.
I'll just bring Nuria in because Nuria was involved in this for some time. I mean, I think having a new thinking and direction for this group is a really good idea. But Nuria, you expect.
I think
So the first thing I want to say is that I think this is really, really, really important, and that we know for some time, we've known for some time that we need those equality impact assessments. We know for some time how important this is to all of the business of the board. And I really welcome what this group is going to achieve and what the thinking is behind all of this. I think there is also not just about the protected characteristics and flagging out our duty of equality, but also about promoting equality and cohesion to our community. So I think that what you've described is actually really helpful in that respect. And there's so much more we could do. In terms of the stakeholder reference group, I chaired the stakeholder reference group until very recently. And the group does have representation of all of the different protected characteristics areas, and some were weaker. The group has gone through a lot of thought of how can we provide that advice to the board in its best format. And I think it's fully supportive of the proposals that we're pushing forward. So I think that those conversations have already happened, just to give you assurance on that respect. That's all I wanted to say. I do have a specific question, which is around when we're asking to record protected characteristics at the moment, a lot of organisations, this goes back to HR, a lot of organisations are now going through a blanket way of doing it, so you don't actually say where you fit in. So it's just something to think about, but not something for necessarily for now, something to think about moving forward in the future.
I think we'd heard before, hadn't we, where people were given the option of to fill in characteristics. There's a box prefer not to say box is the box that's
Yes,
often ticked.
it's exactly, yes, and that seems to be the new move.
In the workshops, that's quite interesting, because whether that is a certain cohort, and then you've got the cohort that we were talking to, where it was very clear that they were fed up raising the same issues and having to go through different sort of information sharing processes, when they were thinking, we told you once, why can't you just sort of record that and then treat us bearing that in mind? So I think we've got different cohorts of individuals.
I think it's just being cautious of where we're leading with the equalities agenda and the changes that are coming up.
And just picking up on the final part of your point, Steve, the way in which it advises the board is through reports that come in at the governance section at the end. So we have a report from the Health Professionals Forum and the Joint Partnership Board and the Stakeholder Reference Group, but there haven't been so many from the Stakeholder Reference Group recently.
I think you have until now, so
Yeah.
this is a new change.
Yeah, this week, so that's how it can go forward. Good. Thank you very much, Richard. We can't see any more questions coming. That was a good discussion, and very good to see. Okay, so we're now moving on to section 5, which is population health and partnerships. There is only one item here, which is the key issues report, which I will take as read. I mean, I think what I would say, I'm chairing this currently just to get it started, and because other IMs are fairly tied up with other committees at the moment. I mean, I don't know whether you want to come in on this, Keith. I sense that we are starting to get a bit of a rhythm to it. And I think some of the points that Nuria and Keith raised earlier in terms of the interrelationship between so much of what we do and the population health strategy is becoming apparent through this committee. But I would say it is still at a relatively early stage. We've got some quite meaty reports coming to the next committee as well.
Yeah, I think the committee's discussions were getting to the heart of, well, what is the cultural, behavioural and organisational shift required to become population health competent, and we're getting into that. And recognising, and keep reminding myself, recognising the distance we have travelled down that road already, and not to be too pessimistic, but also to recognise the distance we still have to go. It is encouraging to hear the population health strategy being a reference point and a node around which other approaches are being sought to be built. And I think that's welcome, but there is still this tension between looking at, as I said, the generation of health and preservation of health as against treating people who are already sick, and on sometimes the medicalising of prevention. So we're seeking to navigate those, and the discussions are helping us to do that. But yeah, it's hard work, isn't it? Because if it was easy, we'd already be doing it.
Exactly. Good. Any questions, thoughts? Yeah, Marissa.
Yeah, I mean, I think it's an incredibly, I mean, it's embryonic, isn't it? It's just literally, we've had about 2 or 3 meters, but it's a really useful kind of helpful point to actually, there's stuff I'm learning from the papers that are going in there in terms of why RPB is the way it is and the legislation behind it. So it's actually some of those kind of things are actually very helpful just for everybody to have the same understanding of what they're about. But I think I agree with Keith. I think we've got a long way to go in terms of thinking like a part of a system. And I mean, we had discussions this week with the local authority, and I think that is a cultural shift. It's about changing the way that we think about our input into services. So and that is you know, there's work to do there, but at least we're talking about it. It's if we weren't talking about it, then it wouldn't be something that we could then move on, I suppose.
No, I'm hugely encouraged by the conversations that we have, because there is a long way to go, but we haven't talked about it in the past.
Yeah.
And unsurprisingly, that means we haven't made a lot of progress. Good. Okay, we're on to part 6, governance. Item 6.1, key issues report from the Mental Health Legislation Committee. Steve.
Yeah, okay, so this legislation committee deals with 3 basic pieces of legislation. So just a couple of points from each of those. The Mental Health Wales measure, the thing to note there is, sorry, my voice is, no. The thing to note there is that, again, we have variable performance in CAMS, and we've talked about that already this morning, so I won't rehearse that. Second, the Mental Capacity Act. Now, this has been an area that we've talked about a lot at this point, because DOLS was turning into LPS, and then it wasn't, and then back again. We weren't quite sure how we were going to be organising our LPS stroke DOLS, and then back only to DOLS teams. But there's been a lot of work done, and I think a lot of progress made. The responsibility for the mental capacity compliance has now passed to primary care. The nurse director is leading that project. She is she presented to the committee, she's building up a team, a dedicated MCA DOLS team with a new DOLS lead. And real progress is being made. They have maintained themselves on the risk register at 20. I think they're new to the thing, and so they are a little bit conservative. They need to build up the team. They need to get the training culture embedded not only into the team but into the workforce generally through the systems. And there's also a little bit of we only have the two full-time business interest assessors still, and we only have funding for them. We feel we need more. And so they're working on building that up. Business interest assessors, by the way, can also act as discharge assessors. So when you've got clinically optimized people, and the reason they're there is because there's question marks about mental capacity. These guys can go and help with the assessment, and they've actually helped get people through the system more quickly than otherwise would have been the case. So that is real progress. Jackie's gone now, but she was having sat on this committee for some years, she was visibly happy as a consequence of this presentation. HIW did an unannounced visit to Caswell Clinic. That's I think it's the medium secure facility at Bridgend, which is a little bit of a challenging place to go, but HIW found no immediate assurance required, so that was a success for the mental health group. And yeah, that was under the mental health. That was number 3. So that's it. Good progress, especially under DOLS. So good news to report.
That is good.
Any questions for Steve? No, thank you very much, Steve. We now have the Charitable Funds Committee key issues report. Nuria?
Again, the report is there for noting. I would like to alert you that the Helping Hands fund has run out of money, but alternative opportunities to fund projects are being sought as part of the new strategic approach moving forwards. Our expenditure has exceeded our income for the first 5 months. This is partly due to lower legacies and grant income. And I can advise you the work is underway to look at our new strategy agreed by the trustees and align a financial plan moving forward. That's all I wanted to say.
Great. Okay, thank you. Questions for Nuria? No, okay. Audit committee, still with you, Nuria.
Yes. Again, the report is that noted. I would like to alert the board of the limited assurance reports we received from internal audit in respect to continuing the healthcare and estates. These will be referred to the other committees as part of our governance arrangements. And advise you that we were assured by the lessons learned as part of the digital issues we encountered in relation to the COVID-19 inquiry, which were discussed by board previously, and that work is underway to align our counterfraud risk with the risk register, and that the counterfraud team have launched a new fraud-focused blog-style diary, which is really helpful.
Thank you. Questions for Nuria? No, okay. So we now move on to the board effectiveness action plan.
Yeah, so
Yeah.
this year we had an external assessment of our board effectiveness, and we've developed an action plan taking on board the recommendations from that report. We've also included the recommendations from the structured assessment report by Audit Wales and incorporated them in the action plan that's presented to you. Just want to draw the board's attention to it was a positive report overall in terms of recognising positive board culture, good dynamics, respectful and being open. 3 areas for development for us to take forward, which we've already started to do in terms of board and committee meetings, more corporate agendas, and we've started to do that with the board and committees. Risk management is about embedding it more, recognising we've got good processes and frameworks in place, but it picks up on Rina's point earlier about starting to see that risk is mentioned in more reports now, not just the risk report. And then the 3rd area is the connectivity between the board execs and service group directors. So we've got development sessions planned to take those forward.
Great, thank you very much. And there's quite a comprehensive action plan, which is good, which reflects both structured assessment and the Deloitte's report. Nuria.
I think it's really welcomed. I think we are looking forward to the management response in terms of how we approach this next from the audit committee's perspective, so that we can hold you to account, not just for what you've agreed you will deliver, but the timings of this. Some of them already look slightly unrealistic when it comes to the Deloitte report. So we'll have in those scrutiny updates from you and making sure that we have that management response so that we can hold you to account.
Yes.
That's all I wanted to say, both from the structured assessment, but also as importantly from the Deloitte report. Well, at the moment, we just have a list of dates, but actually we need to know what the actual response is.
Yeah, so that's going to audit committee and yeah, it's on the agenda.
That's all.
That's great. Thank you, Nuria. Other thoughts on the board effectiveness action plan? No. Good. No, that's great. Thank you. And it was a very useful process, I think, getting Deloitte's and getting an external perspective was a very useful thing to do, I think, wasn't it? Good, okay. So now item 6.5, a report on corporate governance issues and also to approve the Waste Committee's standing orders.
Yeah,
So,
there's a number of items there for noting and in relation to matters considered in committee, Welsh Health Service, business cycle and common seal. The main issues for the board's attention today from the report is the committee terms of reference have been reviewed. They've all gone through the committee, so they've had discussions with IMs and execs through that process. So the presented to you for approval. Changes are set out on pages 3 and 4. And also the list of standing orders, they've gone through all the committee and just you for approval.
great. Thank you. Are we happy to approve those? Great. Thank you very much indeed. So we now have the summary reports from the Health Board's advisory groups.
Yeah, so the Health Board has 3 advisory groups: Health Board Partnership Forum, Health Board Professional Forum, and the Stakeholder Reference Group. As we've heard, Stakeholder Reference Group hasn't met, but we support that, and hopefully there'll be a report to the next board. In terms of the Health Board Partnership Forum. They met on the 5th of October, and that session was a focused workshop focusing on the engagement with the strategy. Staff attended, focusing on the annual plan, so that was a good session. And then from a Health Board Professional Forum, they met on the 11th of October. A number of presentations, continuous flow model, which we heard about from Marston, the people strategy, recruitment and retention, and anti-racist Wales employment action plan. So they've had a number of presentations and they meetings. So those two partnerships, those two forums seem to be really flourishing at the moment, because it wasn't so long ago that we were struggling to get them up and running. So we provide support to the stakeholder representation.
That's great, thank you. Just wanted to bring in Judith. Was there anything you wanted to add as the joint chair of the Health Professional Forum, Judith?
No, I think still an evolving group. We do need to get further representation and start to receive and influence some of the work that's going on within the Health Board at the moment. It's still receiving information, but it's good to see that it is starting to pick up.
Yeah.
So
Yeah, and the offer for support or attendance remains there. I've mentioned it before. I or anyone else is very happy to come along. I think you're right. It needs to be more discursive than feeding in. So great, thank you.
Thank you.
Any questions on those? No, excellent. Any other business? No, yes,
If I may.
Yeah.
There's been a lot of talk during the day about the fact that Swansea Bay is now a system of hospitals rather than 3 standalone hospitals. We were at the MIU at the beginning of the week, and we heard about, if somebody turns up at MIU with an injury which really has to be dealt with at Morriston, they call an ambulance, and because they're in a safe place, the ambulance might be 4 or 5 hours before it turns up. We have talked in the past in this room about a dedicated Swansea Bay ambulance transfer system, and I wonder whether any further thought had gone towards this.
I suppose to me there's a transport system and there's transferring people who are unwell and require treatment in transit. And I suppose the difference there is, if it was for MIU, and that bring there, if it was for MIU to ED, we wouldn't want a minibus type thing. We'd want skilled professionals.
Yeah, it has
to the ambulances.
It's an ambulance service, but rather than using West, have our own dedicated, maybe a vehicle that West dedicates to us, or our own trained people on an ambulance.
There's a balance.
Yeah, just think behaviourally, there's a risk there that we actually encourage individuals to turn up at MIU when they should actually be going directly to ED. So what we're trying to do is get those who are appropriate for ED to go to ED. Really interestingly, the other way around, those who've got minor injuries turning up at ED, we are actively encouraging them to go to the MIU, and sometimes there's taxis involved. So it works that way. I'm not sure it works the other way.
Sometimes it does, sometimes it doesn't. So the debate we have with WAST, so WAST will not take patients, so that the ambulance will not take patients from one hospital to another hospital unless there's a real clinical need as to why they need to go there. It's a community service, and they will say their route is from the community into hospital. It's not from hospital back to the community. What we've got in place at the moment, so we've got the acute critical care transfer service, which is an All Wales Commission service that we got 8 till 8. Predominantly that service is West Wales. It's an All Wales Commission service, but the Grange has its own dedicated £5 million service that it uses between its hospital sites, so it doesn't use it. Cardiff doesn't transfer many patients because most of them are where they need to be in the first place. CTM, similarly, they've got critical care on each hospital site, so they don't transfer many between them. So that service is predominantly being used for Swansea Bay and Howard Down. And that will only take patients who require timely transfer either to critical care or back to theatre between the two sites. That's the bit that we're trying to extend at the moment, from 8 o'clock in the evening to 2 AM in the morning. And we're working with EASC and the ACCTS team to extend that commissioning. At the moment, it looks like we'll have something in place in January, But that's likely to only be 3 days a week while they work through how they shore up the recruitment to get that in line for us. But for non-critical transfers, then we don't have anything really available at the moment.
No, we heard, didn't we, Rena, that a couple of times the air ambulance has come to Neath Talbot to pick up an MIU patient that was gone to completely the wrong place.
Yeah. And sometimes those will happen, so out of hours, that will be a 999 call. So WAS will triage them appropriately. We used to get quotes so that a patient was in a hospital, it's a place of safety and they didn't respond. That doesn't exist anymore. It's literally the call goes through to the call handler, they triage that call in the same way as they would triage something in the community. They will look at what facilities you've got available to stabilise patients on a hospital site, but in that eventuality, you know, a walk into MIU could come in with arm pain and it could be, you know, cardiac arrest and they go off in the waiting room. So you've got to get them urgent attention. So those things do happen. But Richard's right, we try and promote patients going to the right place at the right time.
And that's similar setup in our GP practices.
Yeah.
It's seen as a place of safety. And I believe that I was.
Yeah.
Okay. Oh, yeah, Darren, I knew I'd seen it happen. That was our answer. Oh, so Anne-Louise.
Yeah, it arises out of this. I think obviously there's a risk, and I agree with Richard. One of the things that we were told was that there are efforts being made to try and stop the wrong people coming to the wrong hospital. But there is a real risk for both staff and the patients when they are critical, and there aren't sufficient people, there aren't people with the skills to manage the kind of criticality that sometimes comes into the MIU. And anecdotally, I accept, we were told that the waiting time for an ambulance to come in those circumstances can be very long, and it puts the staff under pressure because they aren't doctors, they are nurses, and they are stuck. Yes, it's a place of safety, it's safer than being out on the street or wherever, but one or two of the stories we were told were hair-raising, and it puts us at risk for not being able to provide proper care in a timely fashion.
Richard?
Yeah, I think it's an interesting point. I think volumes are an issue in terms of, I've alluded to how much an Iron Bevan service costs. And the reality is that wherever you have your services, there's always the potential for somebody to turn up in the wrong place. It's not unusual to have ladies who are about to deliver, didn't know they were pregnant, to turn up in the wrong place. And as Gareth has alluded to, GP practices as well, people will become critically unwell. And again, people have a degree of clinical knowledge there, but not necessarily the full knowledge. And I think it's just us trying to direct people to the right places as best we can, to have contingency plans, but I'm not sure that we can plan for every contingency.
No, and that is, we do have an ambulance service, a transfer service that is commissioned. Yeah. Okay, any other, Richard?
One other thing that we're working on, which hopefully will help, is signage around the locality. So some of the Darren's team is liaising with Neath Talbot Council just to see whether we can change the signs from the red H signs that are all around the place to something more sort of calm and so it indicates that there isn't an emergency department there. So that work is ongoing. The council has been approached and we're waiting for them now to basically implement a new arrangement. And I think we look at that in other areas too.
Fine, thank you. Sorry, Dad, did you, that was your way up? No, thank you, thank you. Okay, all right. Thank you all very much indeed. If we just, yeah, thank you very much indeed. I think that's the end of the board meeting. Good. Right, just a couple of minutes, if you don't mind, review the long board meeting. It's a very heavy agenda. That was the way things fell.